Thank you, everyone, for your patience. We will begin shortly. Welcome and thank you for joining the Pregnancy and Asthma webinar today. I am Destiny DeWalt from Esperanza Community Housing Corporation in South Los Angeles, and I will be moderating today's webinar. Before we begin, I would like to start off with some webinar logistics. Everyone on the webinar will be muted. If you have a comment or question during the presentation, please use the chat box to send a chat to all participants. The presenters may miss a comment if it is a direct message. The webinar will be recorded so you can watch it again in the future if you wish. The link for the recording will be included at the end of the webinar. At the end of each webinar, there will be an evaluation that will open in a separate window. Please take a minute to fill out the survey to help us make each webinar better. Thank you in advance. This 6-part webinar series was developed by the Asthma Management Academy, a professional development opportunity developed in 2016 by the California Department of Public Health. Esperanza Community Housing Corporation and Comité Cívico de Valle, the Management Academy, was developed for community health workers and health educators to support them in educating their asthmatic clients on self-management and prevention. Our topic today is pregnancy and asthma. In April, we heard from Maria Bajarano and Consuelo Bernia, two promotoras from Esperanza Community Housing. Today, we will do a short summary of what they talked about, and then we are very excited to welcome Dr. Li from the BreathMobile in LA to share her knowledge and experience with us. Next slide, please. Next slide. So to recap what we discussed in April, the main barriers that are seen with pregnant women with asthma are fear the medication will put unborn child in danger, difficulty controlling triggers, not going to prenatal visits, no communication with doctors and other healthcare professionals, language, and lack of insurance. Next slide. The recommendations and the education that we felt best suited these concerns are talk with the doctor about any concerns, thoughts about the steroid medication use, make an appointment with an OBGYN and ask them about medication concerns as well. Recommend that she ask the doctor for an interpreter during visits and to explain medication use, and obtain an asthma action plan. At this time, we would like to welcome our clinical subject matter expert, Dr. Marilyn Li. Dr. Li is an associate professor of pediatrics at USC Keck School of Medicine, Section Chief Outpatient Services of Allergy and Immunology Division, Allergy and Immunology Fellowship Training Program, Assistant Director and Co-Director of the BreathMobile Program at LAC+USC Medical Center. Dr. Li is an ambassador for the BreathMobile program, presenting asthma disease management principles at various local, state, and national meetings. Her interests include improving patients' understanding of asthma and their medications. Welcome, Dr. Li.
Thank you very much, and thank you all for attending this webinar at this hour. We have a lot to do today. Certainly, asthma itself is a huge topic, and addressing pregnancy in asthma means sort of speaking a little bit just about asthma itself, and talking about some of the special points that pregnancy and asthma have in addition. Next slide, please. So there are no disclosures for this activity. Next slide. The objectives today, there are many, and in truth, we will touch on these objectives. There will be resources available. At the end, there's a resource page with links or article names to refer to. There are many. Number one, we would like to define asthma. Number two, discuss asthma in pregnancy. Number three, apply the Expert Panel Report 3, or the EPR 3 guidelines, and briefly discuss the 6 priority action steps, which apply to each and every patient with asthma. 4, understand application of asthma action plans for patient self-management. 5, to discuss some of the barriers to well-controlled asthma, although in the previous 2 slides, actually many of those barriers have been discussed. And number 6 is to review and demonstrate some of the medications for asthma. We may not go into great detail, but that is something that would be very important with each home visit for a patient, whether they are pregnant or not, who has asthma. Next slide, please. So just to define asthma again, asthma, the pathologic features of asthma include the inflammation, which is, of course, the swelling inside of the airways, the bronchoconstriction, where the muscle bands in and around the airways tighten and constrict, creating the shortness of breath, chest tightness, and wheezing symptoms. And number 3, the increased mucus production that can potentially block the airways. Next slide, please. One of the best teaching tools, and certainly I know that a great teaching tool that is in the Asthma Academy's toolbox, are pictures. And teaching, education is the cornerstone of helping patients with asthma, especially patients who are pregnant with asthma. And so to just review briefly normal versus bronchial inflammation is an important sort of information points to review with each and every patient. Next slide, please. So asthma in pregnancy, the prevalence varies, and it varies widely depending on which article or which organization you look at in terms of statistics, but the numbers vary between approximately 4% to approximately 14%, with noted increases in the recent decades. Maternal asthma during pregnancy does increase the risk of poor perinatal outcomes, and the 4 in particular include low birth weight, preterm delivery, preeclampsia, and perinatal fetal death. Difficulties, of course, there are many difficulties in studying the pregnant population itself because clinical trials, trying medications in pregnant patients would be unethical. So pregnant women with asthma and some providers are noted to be hesitant to use inhaled corticosteroids for persistent asthma. And that's actually, I think, one of the main points of this webinar, which is to discuss the important role of medications in helping patients who have asthma who also become pregnant. Next slide, please. So there are many factors during pregnancy that influence asthma in asthma patients. There are surging levels of cortisol and progesterone, and they do change rapidly through the 9 months. Studies have shown that 36.3% will have a deterioration in asthma control during the pregnancy, so asthma patients who become pregnant. So approximately a third, a little more than a third, will have worsening asthma, and approximately a third will have an improvement in their symptoms, and approximately 26% will have no difference in their previous versus pregnant state asthma control. During pregnancy, however, asthma exacerbations can occur, and it does occur in almost half of pregnant women who have asthma. And in that almost half, just to make a point here, is that patients who even were previously, prior to pregnancy, diagnosed with mild asthma or mild persistent or even intermittent asthma do make up a portion of that 45% who have an asthma attack during pregnancy. So having mild asthma prior to pregnancy doesn't mean that they will have mild asthma during pregnancy. It's still a risk of about a third, a little over a third, having a deterioration in their symptomatology. Allergen exposures in an uncontrolled asthma patient can also trigger asthma exacerbations, and smoking, or smoke such as tobacco and other sources, can certainly trigger asthma. Next slide, please. So there are consequences of poor asthma control in pregnancy, and because of exacerbations or because of the poor consistent asthma symptomatology during poor control during pregnancy, children can be born with low birth weight. There can be prematurity. More are likely to be delivered via C-section. And there are some reports of congenital malformations. And again, to emphasize the point, almost half will have an asthma exacerbation sometime during the pregnancy. And many of the time, it actually occurs between the 24th and the 36th week. In addition, approximately about 6% actually, of 6% of these patients will actually also wind up in the hospital and be hospitalized. Next slide, please. So the guidelines, the most current United States guidelines is the 2007 National Heart, Lung, Blood Institute Asthma Guidelines. And that document is 440 pages with several summary sections. And in general, you know, when we diagnose a patient with asthma, we initially would diagnose severity, and of course, thereafter, we always assess asthma control. And so that's the major concept in the tome or that book of the National Asthma Guidelines in the United States. The goals include the prevention of chronic day and nighttime symptoms, the maintenance of optimal pulmonary function testing, patients having normal activities, things that they enjoy doing in or outdoors. Of course, an important goal is to prevent exacerbations using therapies with minimal or no adverse effects. And during pregnancy, there is the additional goal of maintaining fetal oxygenation throughout the pregnancy. Next slide, please. This is actually a specific document on managing asthma during pregnancy put together by a work group that consisted of both allergy as well as OB/GYN physicians. Similarly, the key concepts or the core concepts are the same in terms of asthma control and keeping patients under good asthma control. Next slide, please. So there are 4 key components, and I'm going to just start off on your left-hand side, which it says measures of assessment and monitoring. And this is probably the key. Earlier, we saw a few slides from our promotoras that talked about, partnering with primary care, seeing your OB-GYN. But in addition, I would actually like to advocate that patients who have asthma also see a respiratory specialist with regular checks. And it can be with primary care as long as the focus of the particular visit will also focus specifically on asthma and reviewing the asthma control parameters. Initially during pregnancy, we recommend once a week until asthma is well controlled, and then once a month throughout until you get to the third trimester, where you might have more frequent monitoring again. And actually, I would also like to make a point that prior to pregnancy, so for all preconception women, patients with asthma who are interested and are of the childbearing age, I think it's important for physicians to have a dialogue, as well as healthcare workers to have a dialogue with that patient to talk about the issue of asthma and pregnancy, and to set the stage about talking about the treatment options that should continue throughout pregnancy with good monitoring. We're going to go to the next, the bottom, your bottom left-hand corner. It says control of environmental conditions and comorbid conditions. Also, very important cornerstone to review. If a patient is a smoker, clearly the patient should be advised about, stop smoking. So smoking cessation prior to pregnancy, during pregnancy, at each visit, to encourage that patient to really think about what's good for their health and to review that tobacco smoke is certainly has many public health as well as individual health hazards. On your right-hand side on the bottom, it talks about pharmacologic therapy, and I think that goes hand in hand with the upper right-hand corner, which is the education for a partnership in asthma care. And education is key. I think people, and I know that is your objective, is to really teach people about asthma and about asthma care and the rationale for the different components, including medicines, trigger reduction or avoidance, having regular or long-term care, and really understanding the role of healthcare and obtaining well-controlled asthma. There's actually a study that was published in 2005 in the European Respiratory Journal, and that examined if education could improve outcomes. And in their little group, they found with their surveys that 40% of their asthma patients who became pregnant were not on any inhaled corticosteroids. Although these were identified as persistent asthma patients, also 16% of those patients did not inhale or take the medication with proper technique. 42% of those patients did not know about why asthma medications or anti-asthmatic, that particular group, inhaled corticosteroid medications, what they did or why they were important. And initially, 15% of that group had asthma action plans, and only 3% of them knew how to do a pulmonary function, peak flow, a measure of pulmonary function, so peak flows, and do them consistently throughout their life with asthma. After intensive education and after the second visit, it got better, but still 21% were not on regular continuous treatment. About 4%, so down from 16%, about 4% had poor technique still. But, key point, 95% of these patients, with just a good educational session initially, 95% understood. They understood about their medications, they understood what asthma was, and they understood the role of the medications in treating asthma. The number of patients who received an asthma action plan and knew how to execute it was 75%, and 35% also learned and retained the knowledge of how to use peak flow meters. And I think in general, having something like a peak flow meter, in addition to the regular checks, is reassuring and helpful for patients to understand their asthma control on a daily basis. Next slide, please. So I'm just going to go through these slides very quickly because they're really there for your reference. These are some stepwise approaches for managing asthma during pregnancy and lactation, and it goes through similarly the steps of therapy as in someone who is not currently pregnant. These are available in the document Managing Asthma During Pregnancy that was put out by the Working Group for Asthma in 2004. Next slide, please. This is a slide that shows some of the typical medications used for long-term asthma control during pregnancy and lactation, and also on the bottom gives some of the different types of inhaled corticosteroids and the relative dosing ranges of whether it's low, medium, or high daily doses of medication. So you have some idea of what type of severity or what step of therapy a patient is on by just looking at their medications. Next slide, please. Now, this is figure 6 from that working group document, and it talks about the different medications that you might use and the typical doses so that you would understand what the short-acting ones are and certainly what the typical doses are, what the systemic, the anticholinergics and the systemic corticosteroids. Just a quick note here, prednisolone is probably the preferred oral corticosteroid for pregnancy due to metabolism issues. Next slide, please. So the 6 priority action steps in sort of evaluating and starting patients who have asthma on therapy are the same for an asthmatic who is or isn't pregnant. The number one goal at any initial visit is to assess asthma severity, and of course during follow-up visits assess asthma control. Clearly for persistent asthmatic patients, using inhaled corticosteroids is an important piece of the pie. Using asthma action plans is another important piece of the pie. And scheduling follow-up visits, also very important during pregnancy, might have a higher frequency of checkups. And of course, with good, well-controlled asthma during or after delivery, scheduling follow-ups at an appropriate interval would still also be important, and clearly to control environmental exposures. Next slide, please. I want to focus a little bit on asthma action plans. That was highlighted in the first 3 slides, and it should be highlighted everywhere. They should be in a marquee with neon lights. Every patient who has asthma should have an asthma action plan. And the purpose is multifold, but it does empower patients to manage their asthma. It allows them to understand quickly what their daily management plan is, and it is also a communication tool between the providers, each of the providers a patient might have, the patient and other caregivers. And so that particular asthma action plan with a pregnant patient can travel with her from the primary care to the OBGYN to this respiratory specialist. Next slide, please. So clearly on the asthma action plan, there's typically 3 zones that are marked. Asthma zone green, which is the go button, which signals that patients are doing well. Peak flow meters, and in pregnancy, I would highly advocate for understanding pre-conception peak flows to actually chart conception peak flows to help them have a more objective number. Clearly, we go by symptoms in evaluating asthma, but also as pregnancy, when you advance from first to second to third trimester, clearly there is some shortness of breath associated, for example, with pregnancy. So having peak flow meters and numbers can be quite helpful. The green zone also lists all of the asthma medications and the controller therapies, the name, the dose, when to take it, and then also there are notations typically on an asthma action plan to remind patients to rinse their mouth, for example. And there are peak flow areas where you can kind of put in their peak flows and encourage them to keep a peak flow chart or diary. And of course, an asthma action plan can include their allergy medications should they have the common triggers like allergic rhinitis. Next slide, please. The yellow zone is caution. It's where they start to feel some symptomatology or they might feel worse. So the peak flow meter readings might fall, and they typically do between 50 and 80% of personal best. It lists the rescue medications, the name of the medication, the dosage, and when to take it, and it advises that patient what to do when symptoms and peak flow meter readings improves, or if it doesn't improve, you would slide down to the next slide, which is the red zone. And of course, that's where you really want to seek urgent emergent attention. And it also lists what to do, where, and what to evaluate for, and advises when to call for emergency help. On that particular box, it might be good to put all of the phone numbers for the different providers involved in your patient's care. Next slide, please. So scheduling follow-up visits, and so how often? And again, it is highly individualized. It should be tailored to that particular patient. Should the patient have poorly controlled asthma or difficult to control asthma, that patient should be seen much more frequently. But at 32 weeks, certainly working with the OB to consider serial ultrasounds as well as a respiratory check would be an excellent idea. So what should happen at follow-up visits for our pregnant patients? Pregnant patients should be instructed to be attentive to fetal activity. They should complete the asthma control test or some other measure of the evaluation for respiratory symptomatology, spirometry, or peak flow meter monitoring. And actually, nowadays, in many respiratory specialty centers, we have another type of test called the fractional excretion of nitric oxide, or the phenos. And those actually have been evaluated to help manage patients during their pregnancy and to be able to understand whether we might even use pheno measurements to help patients step up, stay the same, or step down on their medications during pregnancy. So there are studies in progress for that, and that looks very promising and would be available at a respiratory specialty center or group. So the other part that should happen at follow-up visits is to discuss adherence, review the medications and the inhalation techniques, and again, stepping up or down or staying the same on a medication plan should also occur during pregnancy, and it's based on some subjective as well as objective data. To review and update the asthma action plan with any medication change, and to manage the comorbid conditions and the environmental triggers as best as a patient can. And always, prior to leaving, have that next visit scheduled and in hand. Sometimes patients leave in a hurry, or they'll say they'll call back. Better is to just make sure they take this couple minutes to have it in ink and or on their phone when they're coming back for their next visit. Next slide, please. So controlling environmental triggers and exposures, typically there's two ways to identify IgE to whether it's pollen or other environmental triggers like dirt, dust, animal dander. And so during pregnancy, we typically would not, we probably wouldn't do a skin prick test and have someone be subjected to some of the mild discomforts of that. We would suggest doing immunocap testing for those patients if we needed to identify particular triggers to better counsel them on what to do or what to have happen in their homes. You do want to control or reduce as much of the triggers as you can in the context of also providing the education and treating the asthma with the appropriate pharmacologic therapy. It's important to provide culturally appropriate educational materials, and then to follow up on referrals, follow up on resources, especially with a patient who may smoke, making sure we, kind of give them the information on tobacco smoke exposure, but also give them the next step, which is here are the phone numbers, here's the information, and how to, get into a tobacco cessation program. Next step, next slide, please. So we do want to emphasize patient goals during teaching, and maintaining adequate control of asthma during pregnancy is paramount. It is important for both the mother and the baby. We do want to, again, to reemphasize the goals, is to reduce severity and reduce the frequency of symptomatology. We want to improve their sleep quality. We want to avoid having emergent or urgent issues occur related to asthma. And we want to use the medications as prescribed and step up, step down, or stay the same at regular checkups and have a current asthma action plan. Next slide, please. And these are the references that this particular group of slides was put together with. So they are available for you. I thank you for your attention. If you have any questions, please go ahead and type it in. Thank you.
Thank you, Dr. Li, for sharing your expertise on this particular subject. We have a few questions that we had when we were registering for this particular webinar. Some people included their questions. So I'm just going to read these questions here. We can start with these, and if people have additional questions, they can type them in the box as well.
I actually have
Okay, you have them?
Yes.
Oh, no, go ahead. If you have them, we can start with those questions, and then
sure.
If people have additional ones, we'll go from there.
Okay. So I'll just mention. Let's see. We'll start with some of them. So there are links for brochures as on this reference page. And there are many resources online available for both patients as well as for providers. I think for patients, one of the websites I really have loved to refer patients to is the Mother to Baby group. And they have fact sheets. They also have a fact sheet on asthma, very easy to print out and hand to patients, which also includes a selected list of references. So Mother to Baby, you would just, kind of Google that. And it's actually should be, you would Google that, and that's a great reference for patients. There's another question about are providers, or let's see, are they aware that pregnant and newly delivered patients who develop cardiomyopathy are often misdiagnosed as having new onset asthma? And can that be a deadly misdiagnosis? And so the answer is, of course, yes. Peripartum cardiomyopathy is what it is heart failure that occurs during the last month of pregnancy, and it can occur up to 5 months post-delivery. Common symptoms in that include shortness of breath, but they also have other symptoms and other clues that it may not be asthma, including edema, so swelling. They typically develop swelling in their feet and their legs. They also have heart symptomatology, including palpitations. They tend to pee a lot, especially at night. And the diagnosis is different. It's done via echocardiogram. And so I did want to point out that particular question, which is that, yes, when patients are evaluated for asthma, these are some of the things that should occur during the evaluation, the questions about other symptomatology, as well as, the examination may clue you into the fact that there's fluid in the lungs versus having wheezing or having normal sounding breath sounds, which can occur, of course, also in asthma. So depending on the situation, that is an important differential to think about. Another question I have here is, which would be the best controller during pregnancy? Well, that actually also depends. I think the documents with the charts that you have in the talk do list several common controllers that we would use in patients with asthma. There are ones that are preferred. For example, budesonide tends to be preferred for patients who are pregnant who have asthma. But also, depending on the patient's asthma control prior to conception and peri-conception, and what medications they were on at the time, it's a discussion with the healthcare providers as to whether it should be changed or not. And so that's actually something that the patient should be encouraged to partner with their providers to think about, which medications would be best. Let's see. Now, there's another question about asthma prevalence in low-income women and how prepared are family practitioners with the diagnosis of asthma, and how prepared are OBGYN practitioners with the diagnosis of asthma. So the prevalence of asthma in pregnant women is, as pointed out earlier, is between approximately 4% to approximately 14%, and it lies in that sort of range. I'm not going to be able to speak specifically to the statistics in California, although I will say that there is a national asthma registry of sorts, and actually with the CDC, they do break down asthma statistics by state, and so there is some information available. Also, I think our partners at California Breathing may have additional information on specific statistics. In terms of how prepared are physicians in general or healthcare providers in general with asthma, and then also with asthma and pregnancy, is also a variable question. And I think the best answer I can provide is that there are many physicians and many healthcare providers out there who keep up to date and do, what the guidelines are out there for, which is they do what the guidelines suggest. And so I think what's really important is to have a team, for each patient to have a team. And that team should include their OB-GYN, their primary care, and should that patient have more difficult to control asthma or have concerns about any portion of their asthma action plan, their treatment, et cetera, it is also worthwhile to add a respiratory specialist to that care team. And I think that those are summary of some of these questions, right? Were there any others that you wanted to address?
So there are a few questions that we as community health workers come encounter with pretty regularly, and one is, how do if the mother has asthma, the newborn baby will have asthma too.
Okay, so asthma is the cause, or the reason why people have asthma. It is multifactorial, but genetics do play a role. But that doesn't mean it's a direct effect. So if mom has asthma, it does not mean 100% the child will have asthma, but that child does have a risk of having asthma, yes.
Great, thank you. And another question that we come encounter with is, a lot of patients are concerned with the prolonged use of steroids in pregnancy. So do the prolonged use of steroids cause any type of side effects in the baby?
So I think the most important part to kind of take away, that's a very, so I think in terms of addressing that question to patients and the family is to first back up and talk about what asthma is, meaning that it's an inflammatory disorder and that it is chronic. So, clearly pregnancy is a specific period of time, but there's also preconception and then post-delivery. The patient still has asthma. And so I think the important point is that it's about thinking a little bit more broadly in addition to thinking specifically about the pregnancy. But to go back to the question of medicines, it depends on the type of asthma that patient has. It depends on the severity, the initial severity diagnosis, and then it depends on the asthma control as to whether that patient needs regular medication. So if a patient has persistent asthma, they need regular medication. How much of the regular medication? It really does depend on the way that the providers decide to follow that patient during pregnancy. If a provider decides to follow that patient as according to some of these recommendations, which is initially weekly until the asthma is controlled, and then monthly until about the 32-week mark, and then considering, again, weekly checks. If they're having such tight regular care, that asthma assessment can occur more frequently, and the medications can be titrated to the symptomatology control. But just to sort of put in there, too, that it doesn't mean that a patient shouldn't take any medicine if just for the prior 1 week they were under good control, but 3 weeks ago, because they weren't taking their medication, they weren't under good control. So it's very variable. It's important that they have the regular checkups. And I guess that's my emphasis is it really depends on the way that that team has decided to evaluate the asthma and follow it throughout pregnancy. And the steps of therapy still apply, and the stepping up and stepping down typically is a step at a time, not to skip 2 or 3 steps. But it's patient-centric. It's definitely individualized to how the patient is doing. Inhaled corticosteroids, in general, have low systemic bioavailability, and that's actually why we prefer the inhaled corticosteroids to oral corticosteroids. And so I think that's something to keep in mind, that the doses from oral corticosteroids clearly is going to be a lot higher than inhaled. And, of course, as we're trying to reach that minimum amount that patient needs as an inhaled dose, then they have less and less exposure to the inhaled corticosteroid. The baby, the fetus, will have some exposure to the medications, but also many-fold, much, much less than what the mom has. But the emphasis is on breathing well and having good oxygenation for both the mom and the baby, and that really is paramount.
Thank you for that information. Can we go to the next slide, please? So at this time, we do not see any additional questions in the chat box. So if you think of any questions in the future, please feel free to forward them to us, and we can forward them to the people that can get those answers for you. Next slide, please. So this is the contact information. Arden Caffrey is the program manager here at Esperanza Community Housing, and Maria Bajarano was our community health worker subject matter expert in April, and she is also available to answer questions for the community health worker questions. Next slide, please. And that is it. Thank you for participating today and joining today's webinar. And we thank you, Dr. Li, our presenter, for sharing your knowledge and expertise regarding pregnancy and asthma. Please take a moment to fill out the evaluation that will come up after you close the webinar page. We appreciate your opinions and feedback. Our next webinar will focus on healthy homes and asthma. Look out for the invite in the next few weeks. We hope you enjoyed today's webinar, and we hope to be hearing from you in the future.